All right, welcome. Everyone, keep in mind that we're on podcast, so keep your comments PG. Dr. Mallard in the tradition of UK anesthesia. Dority plus keywords plus NeuroAnesthesia equals?
Boring.
Oh, it hurts so bad. How many years more do I have to do that with you? Oh, okay. Full disclosure. Well, it's not my house, so. A lot of this is Dr. Shell's slide. There's no reason to completely start from scratch when you had such good material. Over the years, we've changed these, as most of you have seen. His name is still on the slide, but it gets smaller every year unless he contributes something, then it'll get bigger again. And that's how you know how much of it is his. These are painful and high yield, and I really think this is something good that we do, but it's really hard to sit through them because it's going to just be an onslaught of information. Every year you sit through this, it'll sound different because your brain will process it differently. Keep in mind, just like before, the red italics means help me remember to engage you so you don't just fall asleep. And don't let me skip one because I can't see the colors anyway, as some of you know. One of the questions that will end up on your life every day, whether pimping or for the exam, is the relation of cerebral blood flow, mostly to CO2, and this question is written many different ways. The primary way we write it, or that it is written, is relating to what's the most fast, potent, efficient way to lower the ICP or to relax the brain when there's extra brain bulk, and that's to hyperventilate. I'll say that at least 2 or 3 more times, and you'll see it in text as well. Now the curve, with the CPP curve and the ICP curve on this image, is a little overwhelming, so take off this one and this one, the dotted curves, and your brain will recognize the O2 and CO2 cerebral blood flow curves. The key to this is between any physiologically relevant range or normalcy. It's nitrate my FiO2 and affect brain bulk in any meaningful way. But look at how linear the CO2 curve is. That means we can use this really, really efficiently. Said it twice. Let's see how many more it comes. And it is used routinely to shrink down the brain for either for ICP crises or for neurosurgical cases. On Friday a week ago, there was a patient who had bad lung disease, young, probably smoked, and they couldn't get the CO2 below the 40s, and the whole case was extra bloody and extra argumentative back and forth and increased the tension, and all the variable was we just couldn't blow off any CO2, and it was bleeding. And okay, so there are some other things. CO2 is the most potent regulator. Yes, this question shows up for the rest of your life. CO2, as we know, as it increases, is associated with a respiratory acidosis. So then that begs the question, what effect would a metabolic acidosis have on cerebral blood flow? Or, phrased another way, do your acidic, septic patients have ICP crises? Clinically, no. Otherwise, all of them who get septic would end up with an EVD so we could monitor it. What that means is the H+ itself is not the effector of the increased cerebral blood flow. And you know this because it's not big, but it's a very polar molecule that can't cross the blood-brain barrier. All right, so we'll get back to that list in a little bit. Now, you have to keep in mind that although CO2 is the most potent regulator of cerebral blood flow that I can manipulate, 3, it doesn't last forever. So the books rate this variably. If you say anywhere between 6 and 24 in your oral exam, I'll be happy in terms of hours. 6 hours means that in some cases, even acutely in the setting of an ICU or an OR, we're in the room long enough where our benefit of hyperventilation will start to go away some. Why is that? Well, everything tries to maintain homeostasis. The CSF bicarb production shifts to normalize the pH. Okay, so it doesn't work forever, and it has risks associated with it. Cerebral blood flow. There's actually some pretty specific questions in past years on the IT about this, surprisingly specific in fact. So let's talk about cerebral blood flow manipulation. Hypercarbia, more blood flow. And you know that's true because as soon as you rotate through neuro, we hyperventilate most tumor style cases to decrease the blood flow into the brain so the brain's nice and relaxed. Hypoxemia, only in extreme cases, meaning a SAT below something we're comfortable with. So PaO2 less than 60 or 50 here is obviously 60 is 90, so you're going to have SATs that are not what you want before the brain starts increasing cerebral blood flow. This is intuitive, so don't mess this up on the exam. What would you expect a sophisticated organism to do when it ran out of oxygen? Increase blood flow to the organ that mattered the most. Not the heart for some of you. Hyperthermia increases cerebral blood flow. And the opposite of that is that hypothermia does decrease cerebral blood flow. We'll talk about that more as well. certain drugs increase cerebral blood flow. It doesn't mean ketamine is the wrong answer for most of these. It means you have to have a sophisticated answer to defend it, because in someone who's having an emergent cranium like we did yesterday, ketamine may not be the best answer because we're increasing cerebral blood flow and probably making the brain tighter in the process. How clinically relevant is that? Who knows, but you have other drugs that you can academically defend easier, so maybe that's the way to practice. Volatile anesthetics, uncouple, a buzzword that we'll come back to, and increase cerebral blood flow. The cerebral blood flow is affected by vasodilators, but less so by vasoconstrictors, and that trips you up sometimes. So if I give phenylephrine, if we keep this at the ABA level, okay, we're not going to make this too complicated. If I give phenylephrine, I might have increased cerebral blood flow, but it has nothing to do with cerebral regulation here. It's more because I increase the mean arterial pressure, which then increases cerebral blood flow. If you want to make it really complicated, if we increase the mean arterial pressure, then doesn't autoregulation kick in and actually decrease cerebral blood flow? And you can see how complicated the loop starts to get. Let's not talk about that, though. Vasodilators absolutely do this. So if we're teaching physiology in the ICU, I can bolus nitroglycerin and watch the ICP go up. It really does happen. It really does matter. Why is nitroglycerin more of a cerebral vasodilator than nicardipine? There's more venous blood, say roughly 6% versus 3% in the brain. Nicardipine is an arterial dilator more so. Nitroglycerin is more of a venous dilator, therefore has more of an ICP effect change. Possibly clinically relevant. What it more ends up is that as managing a system, you pick the drug you can defend the best. And if you only had nitroglycerin, fine, use that to lower the pressure in a crisis. Succinylcholine, I don't know the answer to can ICP spike or cerebral blood flow increase be blunted by defasciculating doses. The answer is probably somewhat. Can you reliably protect yourself? Not really. So do you give it? I don't know. It's no different for me than the myalgias. Can I decrease my incidence of myalgias by giving a small dose of rocuronium before sex? Maybe. But it adds a lot of other variables to my life that I don't want to manipulate or try to consider, and it doesn't do it reliably, so I don't do it, as some of you know. All right, what decreases cerebral blood flow? Well, the opposite of those things. Pretty easy, right? Hypocarbia. Keep in mind that if we're decreasing blood flow at some point, that's going to decrease enough that we're going to expose the brain to oligemia. 30 is kind of a magic number that we use. It's not entirely arbitrary. It's extrapolated excessively from TBI data, but it's a good ballpark to go with. If you say anything less than 25 for a routine answer on the oral boards, I'm probably going to attack that and see if you really know what you're talking about. If you say anything from 25 to 35, I'll think that you live in the same world I live and we'll move on, okay? Hypotension, because of the compromise of CPP, can decrease your cerebral blood flow, but again, you can make that complicated by thinking about, well, it's going to auto-regulate, vasodilate to increase blood flow, and it gets complicated. Very simply, if the blood pressure shoots through the roof, there's too much blood flow in the brain. If you drop down to 50 systolic with your propofol, then there's not enough blood flow in the brain. And then maybe those mechanisms will kick in and save you, okay? The way those questions are written are on that first plane, not on the autoregulation plane, at least from what I've seen, okay? Hypothermia we use therapeutically. The question about how much do you decrease CMRO2 and therefore cerebral blood flow is probably relevant. The numbers are written all over the place. Murph teaches a different number than I do. I use 7 because Audi's big SUV, Q7, it's easy for me to remember. What that means is 7% change, or in this case decrease, in CMRO2 per degree Celsius from baseline, which we call 37. If you crunch the numbers when you're sitting in your room today, you can actually see it's probably pretty relevant when we do real hypothermia, like for circ arrest cases. Intravenous anesthetics decrease cerebral blood flow. This is easy to keep in mind because they're coupled as the buzzwords. So I give propofol, the brain falls asleep, it therefore uses less oxygen, therefore it needs less blood flow. The formula for CPP is super high yield. Megan, do you know what the formula for CPP is? Cerebral perfusion pressure. MAP minus ICP. What's the other equation for it in some settings? So in some conditions, the only time I can think of it that really matters in my life is super obesity upside down with renal failure, where the filling pressures are huge and your CVP ends up playing more of a physiologic role, okay? Anesthetic effects. Inhaled volatile anesthetics are direct cerebral vasodilators. They increase cerebral blood flow, but of course not oxygen consumption because the brain's falling asleep. The buzzword is uncoupled. If you say that, I'm reassured that I move on. If you don't use that word, I'm trying to read you and see if you actually know what you're talking about or not. Hyperventilation blunts the increase in cerebral blood flow. This is actually useful clinically. So if I am running a CO2 of 32 and I'm using a little bit of isoflurane in the background during a crani, I know that I'm protecting myself from some of that vasodilation. You can actually cause an isoelectric EEG with volatile anesthetics, but it takes an awful lot. Most of your patients can't handle that much without an epinephrine infusion. Isoelectric means completely flat, and I put that in parentheses you can see there. Nitrous oxide can increase CMRO2 and cerebral blood flow, but when you're using it just as an adjunct, it probably isn't too much of a problem. And consider that classic neuroanesthesia, before I was around, nitrous oxide was used on every case day to day routinely, and you may do it once or twice just for the experience. IV agents are coupled for the most part, so again, I'm repeating myself on purpose. Decreased CMRO2 means decreased cerebral blood flow. These are the barbiturates, etomidate, and propofol that we use every day. Ketamine is the exception that's set above. It actually increases CMRO2, probably increases cerebral blood flow in the process. There is some change in autoregulation and CO2 responsiveness, so we talk about this routinely. The brain will protect itself, but remember, if you're talking about the brain in the first place, it's already injured. It probably has compromised autoregulation, and then if we're involved, we're giving medicines that are probably compromising as well. So don't think it can keep you safe. You still have to keep everything else in control. Mostly I'm thinking hemodynamics and gas management. Vasopressors, epi, norepinephrine, do not cross the blood-brain barrier if it's intact, but if you increase MAP, maybe you increase cerebral blood flow. Some of you will sit here and say, no, this is all super obvious, but consider when you're asking a test question, it kind of gets convoluted in your head. Vasodilators can increase cerebral blood flow, assuming you don't drop the pressure dramatically. Nicardipine we've already addressed, even though I see that it's red. Mild to moderate hypothermia, Q7 from Audi. Autoregulation intact, CO2 responsiveness intact, meaning that we can use this therapeutically, keep autoregulation, keeping us safe, and still manipulate the other variables. So in an ICU setting, maybe less now based on a few papers, but a few years ago we would use this fairly routinely. EEG slowing and increased amplitude, but of course eventually the EEG shuts down as you go deeper and deeper. We use this also for status epilepticus patients, including last week. We start by just breaking the seizure. If the seizure comes back, we take them down to burst suppression. If that doesn't work, we do it for longer. If that doesn't work, well, it's probably the end of the day. Okay. Beneficial in cardiac arrest, this is evolving but still being done. There's a lack of evidence to support hypothermia for cerebral protection, meaning that the largest anesthesia trial from Iowa, from Todd, looked at therapeutic mild hypothermia to protect during temporary clips of or aneurysm clippings, which we're doing less of with all the coilings now, and didn't find an effect. I found something recently that I thought was really great. If you look at all the mouse and laboratory literature, hypothermia for focal ischemia pretty much across the board shows neuroprotection. Amazing neuroprotection. In other lectures, I have slides that I've talked about where the degree of damage is less, the volume of brain matter that's damaged is less. Everything looks better if the mouse is cold. Came across something a couple of days ago that said one of the reasons we may see a differential effect in humans versus mice is what we call comfortable I don't know what the proper term is, comfortable temperature is warmer than what it is for a mouse. So we keep the mice, or maybe I said that backwards, let me rephrase it. We keep the mice at a constantly colder state than they would be if they could choose. So essentially in a lab, we keep the room whatever we like it to be, just like an OR, right? We keep it somewhat cold, but not bad. To the mice, that's actually colder. So it'd be like Fox sitting here in a room where he's like just sitting here mildly cold the whole time. Maybe that chronic stress does some kind of preconditioning, and that actually helps make exaggerated benefits from cold and focal ischemia. Kind of a nice idea. Something we don't think about, right? Everything we've ever based it on is because we have the mouse in a chronic state of stress. Who knows? Keep in mind that the way we teach this at this point is in an ICU setting, including in the neuro operating room. I can't prove to you very rigorously that hypothermia is better for your patients. In fact, we've started turning on the bear hugger essentially when we would normally. Hyperthermia is pretty conclusively bad, however. So this is one of those logical fallacies I talk about, where just because hot is bad doesn't mean cold is good. What do? Avoid hyperthermia and leave it at that. Okay. I've written a few ACE questions on this, and this feels more like oral boards material to me, but keep in mind, I break it up this way. You can do a 50-50 breakup or a 60-40 breakup. 60-40 sounds less like you're guessing to me, and that's why I like it. The brain's two things. It's a brain, and then it's still just a cellular processor. So the 60% is what I call the brain being a brain, or it's the EEG part. So when we give a propofol infusion or run some isoflurane and get the EEG down to silence, isoelectric, that's decreasing oxygen consumption a lot because we're cutting off the brain being a brain. Keep in mind, though, it's still a cellular machine, so the cells and the ATP pumps are still working away. That's the 40%. The only way to slow down those reactions is to lower the temperature, just like any other reaction, and that's another way to slow down cerebral oxygen consumption. So if we're going to do a long clamp time for a ECIC bypass, we'll actually cool down the brain a little bit more, not with an outcomes benefit, with a physiologic benefit here that I can decrease the ischemic stress. Okay, 60-40 brain cell. If you're isoelectric, that doesn't mean you have no oxygen consumption. You still have cells firing away. Cool them down. Questions are written 50 different ways, but that's all it adds up to. How much CSF is there? About 150. It's turned over 3 times a day. That keeps the numbers nice and even. I just do 150 and 750, and it gets answers correct for me. Okay. How much in a day? 750. How much actually in there? 150. Where is it? 50-50 between the spine and the brain. Okay. Good enough for clinical work and good enough for the exams. To remember, if it's the choroid plexus or the villi that produces or absorbs, sometimes I get that confused. It tells you the answer with the word. The plexus produces, or choroid plexus CSF production. So you can just play the alphabet game. The arachnoid granulation of the sagittal sinus reabsorb the blood. This was a test question that I wouldn't have gotten right either from quite a long time ago. Hydrocephalus is found in patients with myelomeningocele. The way to keep that in mind is the anatomy and the processes aren't working, so you pay a price for it. I don't know what the distractors were, though, the other distractors, so it may have been a pretty sophisticated question. Anesthetics can influence the rate of production reabsorption of CSF. Keep in mind, Lasix decreases CSF production. Clinically relevant? No. So I don't even remember the answers. I'm not going to read them to you. Tight junctions in the blood-brain barrier enable us essentially to do most of what we do in the neuro operating room. Molecular movement across the blood-brain barrier. Why does mannitol suck out the water? More or less. Because it's a big fat molecule and chemistry is still chemistry. This brings up the acidosis from the septic patient versus hypercarbia question, so that should link back in your brain okay. The big polar H+ can't cross either. But CO2 crosses readily, O2 crosses readily, and thankfully the anesthetics cross regularly. We need to keep in mind that you can't rely on the blood-brain barrier in the setting of most of what we do. Similar to the compromised autoregulation, the blood-brain barrier is compromised. So any stress essentially is what that adds up to. Any neurosurgery or neurocritical care patient is going to have a problem with that. It's the same seizures even can do this. In my brain, uremic patients also have a compromised blood-brain barrier. Spinal cord blood flow, this is, well, simple for the purposes of the way it's written for the ABA, as far as I can see. Anterior, motor, we'll talk about differential monitoring, SSEPs and MEPs pretty quickly. 2 spinal arteries, what's the implication there? The anterior is more at risk, okay? Unfortunately, the anterior is motor, and I'd rather lose sensation than motor, so that's a good way to keep it, that it's designed in a way that makes it more stressful. How about this clinical question, just so you don't fall asleep on me? After a thoracic aneurysm repair, patients 3 out of 5 strength, bilateral lower extremities. What can we do at this point? Anyone have an idea? We can place the lumbar drain and maybe change the relative pressures and the cerebral perfusion pressure essentially for the spinal cord to help supplement this blood flow, since that's the implication probably is that it was compromised. This is when you end up with the vascular debate. Do you place it in all the cases or only the ones that have problems when it's a procedure with risk? We had a case that had to go to the OR because there was a peridural, I don't remember the details, epidural hematoma related to the drain. So there is it's procedure with risk. My bias, as most of you know, is to not do anything unless I have a strong indication. So if it were up to me, I'd say let's not place one, and then if we have an issue, we'll place one. This is one of those moments where the question was very specific, and you're going to look at it and go, well, I don't know, and move on. When you do the coilings with me, you'll start to get a good feel for this. Essentially, the MCA is what you think of when you think of a stroke on television. The ACA is your legs, so when we do ACAs or ACOMs, we focus specifically on them wiggling their feet, and then we move out of the room. Okay, we keep it very simple because we're just doing the basics here. Posterior circulation, I've taught a few of you this pretty intensely, that they're not going to lose consciousness until the end. You got to think of brainstem kind of stuff. So every time we have a posterior stroke or a basilar thrombectomy come into the ICU, which seems to be every week, I make sure everyone puts end-tidal CO2 on and tells me cough, gag, tongue protrusion, things like that. And as it gets compromised, you can watch it go down. You can watch their volitional cough get weaker and weaker, their tongue protrusion get weaker, or their gag reflex just go away. And that's how we know when they have to go to the operating room. And I think we did that literally last week. All right, do the neurologic monitors. This is high yield. This also comes up on oral boards with my limited experience quite regularly. You just got to knock these things in your head somehow. So D-tab is one of the easiest ways. I don't necessarily remember which specific hertz cutoffs it is, but I can usually get the answer right, which I have seen on these exams, because you can ballpark it. All right. So if it's 2 hertz, well, I know that's really low, so it's probably going to be delta. The way I keep this in mind, alpha versus beta, because they're both at the awake phase of the EEG progression, is awake has alpha, it's another A. That's how I do most of my stuff, if you're catching on. Book beta, so a reading patient has different EEG patterns than a patient who's just sitting there relaxed and awake with their eyes closed. Okay. Yes, this has come up, so keep that in mind. It's easy to keep in mind when you're just using the alphabet sheet technique. It changes with anesthesia. This graph here is probably too small for you to see. The point here is it's progressive. You can watch it on an EEG and actually titrate your induction, or if you're doing pin and barb or something, based on the EEG, and watch as it evolves, and it's a pattern that's easy to recognize. Even if you just do your BIS every day and stare at the waveform every day, your brain will start to see the patterns, and it gets easier to use clinically. When I sat in the room, I would look at the pattern and then try to guess the number based on the pattern, and your brain will pick it up. You just have to be patient with it. One of the things that may show up is you actually have an increased hertz as the patient starts to fall asleep. So with light anesthesia, the way I remember this is, I have said to you before, as the propofol kicks in, you watch the heart rate go up. So the patient starts to fall asleep, and then you see the heart rate go up slightly, and it's not from the pain because that part's already over. I think what I say is the brain's recognizing, uh-oh, something's going on right here. The heart rate goes up at the light phases, so the hertz go up at the right phases, so it's linked in your brain so you don't get it wrong. Okay? That may not be enough to get the question right, but it will be enough to rule out one distractor, which gets you closer. Let's see, we can use all of the things that we use to put the brain to sleep to shift this off into burst suppression. Ketamine's a little funny. This is why when you use ketamine, even the adjuvants that Dr. Mallow and I used yesterday, it affects your BIS number, and you stare at it and you're like, well, I don't know what to do with this, and then I pretend it turned off and then it wasn't working. Hypothermia and hypoxia have similar progression on the EEG. That's kind of neat to think about, because we have seen, depending on what cases you're doing, this evolution in real time on the EEG as the brain cools for circuit rest. Hypoxia would do the same, but I haven't exposed that. Burst suppression is the endpoint. The endpoint's not isoelectric EEG, almost no matter what the question becomes. I've missed that myself on that exam. High concentrations of most of the drugs we use can do this, and again, profound hypothermia can do it. I'm talking like 22 degree, like, circuit rest temperatures. The BIS is a monitor of sedation. You know the numbers here. Isoelectric is supposed to be 0. One of the main questions here is that brain dead does not equal BIS of 0. Those are separate monitors. Don't link those in your brain. That'll come up again. Ketamine, nitrous, xenon, high-dose opioids, maybe. It's harder to tell with the BIS. You live with this, so this is something familiar. Keep in mind that other stuff happens. So I've seen a paper where they bolused esmolol for the stress of DL and saw the BIS go down. Muscle relaxants bring your BIS down. There's a lot of other things happening. It's not like a magic monitor, right? We used the objective train of 4 monitor yesterday, and it worked some, and other times it gave us numbers that really didn't mean anything. It's still a monitor. You still have to use your other impressions to make decisions. Regional anesthesia can decrease risk. You can see that this can be written any way, and the key is to recognize that everything you do will have probably some effect on BIS that you're not going to be able to quantify, so you're not going to know what to do with it. Okay. Brain dead should be 0, but about a third of donors have BIS greater than 0. This will help you. I think it's easy to remember that BIS isn't necessarily 0 in brain dead, at least. It doesn't sound too hard to put that in your brain. Something that makes it probably more relevant, though, is can you use EEG, which BIS is just a proprietary algorithm from EEG, to diagnose brain death. The way to keep that from getting confused in your brain is we don't even allow EEG to be used at UK because it's too fraught with problems for brain death. Okay, it's not an option. If you order it, they'll say, no, we don't do it like that here. Let's get to the neuromonitoring stuff that seems to come up high yield for even a high yield lecture. Evoked potential means, evoked means some stimulus is sent. That's different than an EEG, and I've seen a senior examiner use this on the oral exams. Kind of tell me what this stuff means. If you have an evoked in it, that means we've done something to generate a signal. The EEG is a natural processing. We're just seeing what it's doing, okay? Separate those out in your head, clean it up. Height or amplitude and latency. Amplitude makes sense with an EEG. Latency doesn't make sense with an EEG because there's no signal, there's no stimulus to base the latency on. That's how you can separate it out in your brain. So SSEPs and motor evoked potentials have a latency because they have a stimulus. Okay. Anesthetics decrease amplitude and increase latency. That's intuitive. So if I'm putting the brain or the spinal cord to sleep, the amplitude goes down and it takes longer for communication to happen. So that's what we monitor, okay? And there's specific cutoffs, and they're really ballpark. Like the amplitude, if we have a 50% decrease in amplitude, then we start to say it's clinically significant. Remember, it's a summative, a whole bunch of averages to make a line that the technician and the neurologist can process, so it can't be too particular. Neuromuscular blockade improves signals. This is critical because you can be asked about 100 different ways. You're having a hard time getting clean signals. The neurology team is doing SSEP monitoring for your spine case. What can you do to help the signals? Well, administer the muscle relaxant, eliminate all that EMG variable, and you clean up the signals, and the summation can happen better. If you're doing motor evoked potentials, that's the wrong answer. Okay, right. Brainstem auditory evoked potentials is most resistant. This is when we say, look, you got to be careful what you say. Even though they're looking unconscious, the rest of the brainstem's still falling asleep, and they may have some ability to hear what you're saying. Posterior columns monitored, meaning I can do SSEP monitoring all day and the patient can still wake up weak because they're different parts of the spinal cord, okay? Every time we do a spine case and they say we're doing neuromonitoring, the main question I have for them is, are you additionally doing brainstem monitoring? Because then I have to help place some of the monitors. And are you doing motors? Because it changes my anesthetic most significantly, and it helps me keep in mind what we're actually doing here and separate it in my brain. So I partially do it so that I don't get them convoluted in my head. Subcortical responses are more resistant to non-surgical factors. Another way to say this is the cortical part is very sensitive to the anesthetics, which is intuitive because that's what we're primarily dealing with. We're not administering anesthesia primarily so that the autonomic system doesn't work. We're doing it so the patient doesn't suffer and have the experience. Motor evoked potentials, anterior cord. Yes, we're trying to repeat ourselves to stick it in your head. What I write on our sheets is exquisitely sensitive to help you remember. Anecdotally, myself, I can't seem to run any volatile without compromising the motor evoked potentials. There are big hospitals where they do that routinely and it works. I don't know how to answer that question, but keep in mind, if I'm running motors, then I'm not going to even turn on the volatile. I've told you all stories of running just a little bit of volatile in the induction room while we're getting everything positioned, going into the operating room and the tech saying, did you guys use volatile out there? Because I can tell our motors are awfully disproportionately down, okay? Maybe that anecdote will stick in your head a little bit better. We routinely run Keta, Remi, Propofol here. We don't use high-dose volatiles. And it's not that you can't give any neuromuscular blockade. It's the same principle of how do you defend it? Why are you making it hard if we're monitoring motors and giving neuromuscular blockade? So our culture here is no volatile, no motors. Keep it clean like that. You'll be able to answer the questions. Transcranial Doppler we use a lot when you rotate through neurocritical care. We don't use too much in the operating room, largely technical. If you're having 2 Doppler probes, a head frame on while they're trying to operate, it becomes technically challenging. There's lots of different things here. We're going to high yield. The primary reason we use it in neurocritical care is to monitor for cerebral vasospasm in the setting of subarachnoid hemorrhage. The idea here is that the brain, sensing the blood, irritates, causing an inflammatory process. There's a lot of other things happening, but to keep it simple, the vessels squeeze down and vasoconstrict in response. This causes delayed cerebral ischemia, which causes strokes, seizures, and increased mortality. So we want to monitor that so we can optimize everything to limit the effect of it. How do we do it? We put daily transcranial Doppler probes on. Most of the questions are written looking through the temporal window. African American females have a thicker temporal bone and a higher incidence of having no window. So you'll see sometimes we can only do one side, or we can't do any vasospasm monitoring in the anterior circulation because someone's temporal windows are just too thick and we can't insonate through them. It's important to keep in mind it ends up coming up clinically. There's lots of subtlety to the waveform that we're not going to talk about, but essentially when vasospasm starts to become an issue, it's still the same volume of blood going through a narrow vessel, so the velocity goes up. So if it increased velocities, we start talking about cerebral vasospasm. Maybe we'll augment the pressure to help push blood through more effectively. Maybe we'll take them to the angio suite and do angioplasty, or more realistically, we'll just squirt in a vasodilator into the arterial circulation to offset the vasoconstriction for a few days to limit the delayed cerebral ischemia, most specifically the strokes. Lots of words. Okay. There's a specific number called the Lindegard ratio. If you imagine somebody who has a subarachnoid hemorrhage and they have stunned myocardium, kind of like Takotsubo style that we've all heard about, and they have low cardiac output, well, that means their brain velocities are going to be low too. As the heart improves over the first week, the velocities are going to go up, and then we'll all look at each other and we'll say, so is it vasospasm or is it just better blood flow? The way to differentiate cerebral vasospasm from hyperemia is specifically this Lindegard ratio, defined as the MCA to the ICA velocity. So if I look at the velocities here every day and my cardiac output increases, this will increase proportionally to the MCA velocity. As soon as there's a discrepancy between MCA velocity and ICA velocity, that's cerebral vasoconstriction. Okay. Brain death is an interesting one. This has shown up as well. Seeing no blood flow does not mean brain death. Okay. The way to remember that is if I have a window that can't insonate, I see no blood flow. And if I put my probe on the table here, I see no blood flow. So that's a pretty easy way to keep it in your head. So what do you see reverberating flow? That's this image right here, where it's coming back and forth, oscillating on each side of baseline. The way to think of this is there isn't meaningful blood flow in the head anymore because it's dead. You still have ejection fraction happening, so you have pulsatility that's pumping the blood, and it's just doing this around it. Okay? So if I see reverberating blood flow, that's cerebral brain death. Sorry, that's neurologic brain death. If I see no blood flow, I don't know what that means. Okay? And you see how we're very consciously putting dichotomies out there. If there's only 4 distractors and you get 1 dichotomy, you're so far up in your percentages. Okay. We also monitor, and we use this clinically routinely, for emboli for somebody who's having strokes we can't see. We maybe put the probe on, anchor it, or have the tech stand there for 30 minutes, turn up the volume, and listen for the sound of the emboli shooting off. And of course, there's a image when you're using Doppler as well. OR, we don't use that so much. We have to sit there. The GCS, it's mostly a matter of cortical function. This is when I really start to emphasize posterior from anterior circulation. The posterior may still be awake as their brainstem's cutting off until they hit the tipping point, and then it's an emergency. It's emergency before that, but then it's a disaster. We may or may not, since we're public right now, have lost patients because we didn't realize the neurologic decline because they were still awake until they were dead. Okay, maybe a little bit of exaggeration, but the clinical point is valid. 3 to 15, this shows up a lot. I don't like these questions because I think it's really hard unless you're using, like if they gave you the specific wording in this chart and the chart, well then it'd be easy, but then it'd be too easy. So just like in rounds, the motor response is the one I actually write down. It's the one I can most effectively and objectively evaluate. The verbal response is the hardest. What's confused versus slurred versus not really making comprehensible sounds. I don't know the answer, I guess. If you're close enough on the oral exam, you're good for me. On the written exam, though, that's not how it works. So you'll have to find some way. When you get it wrong, it's because of the verbal or because you have no understanding. But in our case, it's because of the verbal score. Less than 9 is the traditional answer to intubate. Keep in mind that's not for us. That's not for an ICU team. That's for like out in the field and primary care or something like that. If I had less than 9 intubating, every patient I ever take care of would be intubated, okay? So you still have to make clinical rational decisions. But that's what they have in mind, okay? Limitations. We use, if you've been in ICU, the NIH stroke scale because it's so much more sensitive and helps us track progression. There are plenty of patients who come in with catastrophic strokes, let's say a right-sided MCA stroke, hemiplegic, facial droop, and their GCS of 15. The follow commands briskly, their eyes are open, right? So it's very different exams. All we're looking for is a course exam with the GCS. It is validated though, so it does offer information that's useful. Coma versus vegetative state's a hard one to keep in mind. So although there's other sleep disturbance, consciousness disturbance is one. Thinking about the dichotomies again, I've only included these two. Coma has a disturbed wake cycle, sleep-wake cycle, and no interaction with the environment. The no interaction with the environment means you don't have to remember that because they're in a coma. You already know that. So what's the difference? There's no sleep-wake cycle changes. Persistent vegetative state, however, has preserved sleep-wake styles, and essentially they have things that look like something might be going on inside. All right? They might smile, make automatisms, roving eyes, but they're still not interacting with the environment. This is hardest on the family because they think, oh, look, that time it was because I talked to him. Jugular venous oximetry, we're not using as much anymore. We have so many other things now. The LICOX or the brain tissue oxidation monitors is what we're using more routinely. As far as I can tell, there's still test questions on this. This, to me, is for the brain what a PA catheter mixed venous oxygenation is for the rest of the body. What's the normal mixed venous oxygenation on a PA catheter? What percentage? Yeah, I mean, we ballpark it, we say 75. A little bit lower here, the way to keep that in mind is the brain oxygen consumption is higher. All right, so you have someone who's critically ill, they're not moving anything, the oxygen consumption here isn't very much. The brain may be critically injured, but it's still a high oxygen consumer, so baseline is shifted lower. All right, so, well, I think I have a question on it. So you can use this, yeah, as a balance to titrate your hemodynamic, your oxygenation, your blood transfusion, your sedation, your pain control, all of these things in an ICU in real time to optimize this number and possibly improve outcomes. So if I texted that there's a particularly low or high mixed venous oxygen saturation, or more commonly, or what we're talking about here, jugular venous saturations, we have to do something. And if you just think about it, the way you think about a PA catheter oxygenation or a global supply-demand balance, it becomes intuitive and easy to do. So let's take an example. Oh, this question's maybe not the easiest. I probably should put a simpler one in here. From a few years ago, I can't remember where this one came from, 20-year-old TBI, ICU, 85%. So compared to a venous jugular saturation, that's particularly high, okay? So you might say, well, everything's awesome, but you got to think about it as a balance, okay? Intracranial hypertension implies high ICP with low cerebral perfusion pressure. So that's probably going to more classically cause a low jugular venous oxygen. So we can rule that one out. Hyperemia, absolutely, yeah, that may be the answer. All right, so we have luxuriant blood flow, so the central venous oxygenation from the jugular bulb ends up going up. Seizures is probably going to be like ICP, where we're damaging the brain, bad things are happening, so I need to decrease the CMRO too, so the balance can shift back over. So maybe it's hypoxia. This is kind of confusing, but it's also like sepsis. So think about the mitochondrial dysfunction and sepsis. At the micro level, we have decreased oxygen utilization. So you can turn up your FiO2, give all the blood transfusions you want, and the cells are still hypoxic because of the dysfunction at the cellular level, right? We're familiar with this. So sometimes our mixed venous throws us off because it normalizes, not because everything's getting better, because the oxygen consumption is so low, the global balance is shifting up, and we know things are bad, and it gets very difficult clinically to know. The same thing can happen here. If we have a TBI with a lot of anoxic injury or an overdose, like we have seemingly every week, I expect the jugular oxygen consumption to be, the readout to be very high actually, because the consumption's so low. It gets a little trickier, right? I think although you aren't using as many PA catheters and mixed venous saturations as when I was growing up here, if you think about it as a simple brain-focused mixed venous, you'll start getting questions right. That's a lot. No one fell asleep. That was great. Dr. Mallard, look, what was it? Bored. Oh, yeah. Any questions as we tick down on time? We'll do more tomorrow. It'll still be painful and intense.
They're saying like the brain underwent hypoxia, then got damaged, and now is not using oxygen.
Yeah. I think. I don't know what the right answer is. That's what I was going to go. Thank you all. I really appreciate it.